evening. I'm pleased to share with you some thoughts about the role of real-world evidence and the role that regional oncology network can have in this very important field. First of all, this is the list of my potential conflict of interest. So why real-world evidence is becoming more and more important? Because it's very clear that there is an increasing gap between the so-called evidence-based medicine, which is based, of course, on large randomized clinical trials, and the effectiveness of innovation, both therapeutic and diagnostic innovation applied in daily practice. So even though, of course, randomized clinical trials still are considered the top of evidence-based medicine, it's becoming more and more important to be able to derive solid scientific data from real-world practice. And just as a few examples of how this gap between efficacy and effectiveness is becoming increasingly important are shown in the following slides. In this slide, for instance, you can see in the vertical bars which are the percentages of patients, of cancer patients in real world versus, and these are the horizontal bars, the percentages of the patients in clinical trials for different tumor types. And you see, for instance, that women are differently represented according to the tumor types in real life and in clinical trials. Even more evident, of course, elderly patients are very commonly underrepresented in most clinical trials in all tumor types. Same, even more evident for race. Black people is largely represented, and on the opposite side, Asian people are largely overrepresented in clinical trials. And this underrepresentation can have very important consequences. In the next slide, you can see, for instance, the outcomes independently from stage, tumor type, and treatments of breast cancer patients represented, fully represented into clinical trials, the upper line, underrepresented in clinical trials, or not represented at all in clinical trials. It's quite clear that especially non-represented breast cancer patients have a worse outcomes independently, I repeat, from stage, molecular characterization, and treatment. And it's quite clear, so just to summarize from this editorial we have published a few years ago on oncologists, that patients in real life are quite different from patients in clinical trials. And because most of clinical trials in oncology, unfortunately, demonstrate only moderate effect of new interventions, this moderate effect might be completely lost in a real world because you treat patients with worse conditions, more elderly, with comorbidities who take many co-medications. This problem is quite acknowledged by scientists, by statisticians, even though, as you can see from this slide, a very famous group of statisticians in cancer research, the group from Oxford, led by Richard Pito, has recently published an editorial on New England Journal of Medicine, stating that randomization is the magic to provide solid scientific evidence, and the attempt to provide data from observational studies or from real-world evidence is a wrong solution to a real problem. But my point is that it's not a matter of substituting the clinical trials with evidence from clinical practice, but on the contrary, to integrate data from clinical trials with data coming from clinical practice. And this is even more important if we take into consideration the fact that the excellence in oncology is not only provided by a single intervention, a drug, a surgical procedure, a diagnostic procedure, but is provided by the entire journey of a patient from early diagnosis to stage, treatment, follow-up, etc., etc. And just to show how, in a few examples, how all these aspects are important in providing the final outcomes, we can have a look, for instance, to the number of surgical procedures for breast cancer. And you see, for instance, in this slide, and this study is being conducted in more than 1 million breast cancer patients. You see that independently, again, from stage, molecular subtype, and treatment, the outcome of early breast cancer patients is quite dependent from the volume of breast surgeries performed in each hospital. So the worst outcome is in those hospitals where less than 148 breast surgeries are performed every year. And the best outcome is observed in the hospitals where more than 298 breast surgeries are performed every year. And just to again reinforce the role of a regional oncology network, in the next slide you can see how, thanks to the work of a regional oncology network in Veneto region, in a few years the distribution of breast surgeries has changed. You see that in 2015, most of the breast cancer patients were operated in about 40 hospitals, with the majority of the hospitals operating less than 150 patients per year. In 2019, more than 80% of the breast cancer patients in Veneto region are operated in hospitals which operate more than 150 patients every year. Another important point to demonstrate how data from real world are important is timing to treatment. Of course, access to new drugs is very important for cancer patients, but also timing to treatment is very important. And here you see, for instance, in this slide, if you want, rather provocative way, I've shown the importance of a very important new drug for triple-negative early breast cancer patients, the pembrolizumab and immune checkpoint inhibitors. You see that the addition of pembrolizumab to chemotherapy in the neoadjuvant and adjuvant treatment of early triple-negative breast cancer patients can significantly increase the 3-year overall survival, which was 86.9% on chemotherapy alone, and is up to 89.7% on chemotherapy plus pembrolizumab. On the right part of the slide, on the other side, you see how a delay to start chemotherapy, simple chemotherapy, more than 30 days or less than 30 days, has a very important impact on outcome, an impact even larger than the impact provided by pembrolizumab. So again, we need to know data from daily practice. We need to know how many triple-negative breast cancer patients start chemotherapy within 30 days from surgery, and the data are at least as important as the data provided by randomized clinical trials, which has shown, in this case, the importance of pembrolizumab for these patients. And just to show how, if we try to measure these data in the real world, the data are not so satisfactory. In the next slide, you see the time to treatment, time to chemotherapy for early breast cancer patients after surgery in 5 Italian regions. So in these regions, in 2015, we have monitored all breast cancer patients operated in these regions. Were about 16,000 breast cancer patients, and we have detected which was the percentage of the patients who started adjuvant chemotherapy within 8 weeks, not even 30 days, 8 weeks from surgery. You see our benchmark was at least 80% of the patients, and you see that in 4 of these regions we were below 80% of the patients who started chemotherapy within 8 weeks from surgery. And in one region, in Tuscany region, it was even impossible to derive this data. So the journey of cancer patients is very complex, as you can see from the next slide, and the entire journey, of course, can be also evaluated in the entire journey of the patients. And you can, once we have defined the entire journey of the patients, one other important role of a regional oncology network is try to evaluate the cost of a journey of the patients. And you see in the next slide, we have evaluated the cost of lung cancer patients in Veneto region based on what the pathway of lung cancer patients has been defined in Veneto, from diagnosis to stage, treatment, follow-up, and hopefully either cure or palliation and death. And we've published the costs by stage of lung cancer patients according to what is described in the pathway of lung cancer patients in Veneto region. This is, you see the figure on the slide. Then we have followed prospectively 2 cohorts of real lung cancer patients in Veneto region, one cohort in 2015, the second cohort in 2017, and we have monitored and evaluated the cost of what all the procedures done by these lung cancer patients. And you see very interesting finding. First of all, that the cost estimated of the pathway is very close to the actual cost observed for the real patients. The second observation is that in a rather short frame time, comparing 2015, 2017, the distribution of the costs has changed. We have spent much more on drugs in 2017. We have spent much less in hospitalization and hospice care for terminally ill patients in 2017. So the availability of new drugs has allowed to increase significantly the 2-year survival for lung cancer patients. Has changed also the distribution of the cost of taking care of lung cancer patients. More expenses for drugs, less expenses for hospitalization and hospice care. Now, I think we are in an even more complicated situation, because we are now moving from the so-called histology-driven oncology to the mutational oncology. So we are observing a change of paradigms, and you can see, for instance, this slide now, which kind of molecular characterization we have to perform for breast cancer, for instance. Now we have to determine for breast cancer patients the hormone receptor status, HER2 status, BRCA status, PD-L1 status, the PI3K status, in order to provide a complete molecular profiling of the patients, make the right therapeutic choices. But things are moving even faster, and now we move from the so-called, as I mentioned before, histology-driven to the biomarker-driven tumor characterization, where you don't now decide the treatment on the basis of a tumor location, but on the basis of a molecular characterization of the tumor. And we do have, as you can see in the next slide, already some examples of this kind of agnostic approval of new drugs. For instance, pembrolizumab for microsatellite unstable tumors, and NTRK inhibitors, entrectinib and larotrectinib, for TRK fusion protein positive cancers. And if we look to the numbers of patients with different tumor types included in the trials, which have allowed to approve these drugs, you see that there are very, very few patients for each tumor type. So it's quite clear to me, going to the next slide, that we have to integrate data from clinical trials with data from daily practice, from real world, to reinforce the observations reported from clinical trials, because we have to know if those very few breast cancer patients, very few liver cancer patients introduced in these agnostic trials really are reproducible in real world patients, where many more patients, of course, will be treated. Moving to the next slide, this is how, for instance, a regional network can try to afford this kind of problem. For instance, in Veneto, we have implemented one only regional molecular tumor board, and this molecular tumor board has dedicated a very precise pathway for all cancer patients who can be profiled in Veneto region. We have identified the 3 labs where tumor profiling can be done, and we have also identified the centers where these patients can be eventually treated. So going to the conclusion, to the next slide, provocative if you want to I have reverted the pyramid of evidence. It's, to me, more and more clear that we have to move from clinical trials to real-world evidence to provide very solid evidence, especially now that we move to the so-called mutational oncology. And this is my final slide. The network is the only answer which can try to provide data from real world practice and integrate this data from the data coming out from clinical trials. And I thank you for your attention.